Hey everyone, welcome back. We are in chapter 25, slide 28. We are continuing to talk about the respiratory system. We've gone from all the way from the nasal cavity, down the larynx, down the trachea, bronchi, primary, secondary, tertiary, and so on, to bronchioles, terminal, and respiratory. You can see here's a bronchiole. The bronchial branches, here, and at that point, we have a terminal bronchiole. And these terminal bronchioles branch into respiratory bronchioles. The respiratory bronchiole leads to alveolar ducts. Alveolar ducts lead into each one of these alveolar sacs. An alveolar sac is a cluster of alveoli. This is the end of where air comes in. And at this point, air has no place to go, except it can get certain gases can diffuse across the epithelium from this lumen of the respiratory tract into blood vessels or exit, and then you breathe air out. So let's say you have oxygen coming down bronchiole, terminal bronchiole, respiratory bronchiole, alveolar duct into an alveolar sac, specifically into one alveolus. From here, we can enter blood vessels. Let me actually show a blood vessel here. We can enter a blood vessel and take in oxygen, or we can do the opposite, get rid of carbon dioxide. The term alveoli, singular alveolus, is the term for one of these spherical sacs. An alveolus is made of simple squamous epithelium, as we'll see, primarily, so that you can transfer oxygen and carbon dioxide easily. So there's different alveoli that you see here in this histology, which I'm circling. An alveolar duct is what leads to those alveoli. So you can see how there's space in between there, between the alveoli. And then you can see a respiratory bronchiole leading into that. All these alveoli, this is what forms the bulk of the lung. When you look at a lung, what you're looking at, because they're so microscopic, but you're looking at millions and millions of alveoli forming alveolar sacs. And each of these alveolar sacs are surrounded by blood and lymphatic vessels, blood capillaries, lymphatic capillaries. To absorb fluid, as we'll see, will be really important. That's the purpose of lymphatic capillaries, and blood capillaries, so we can exchange gases with each of the alveoli. I was saying that alveoli are primarily made of simple squamous epithelium. These are type 1 alveolar cells. In this histology right here, you can see a single cell. Here's a nucleus, and then a super thin, flat cell, roughly that big. Nucleus, thin, flat cell. Nucleus, thin, flat cell, and so on, forming an alveolus. You want thin, flat cells to allow for gas exchange, so that if you have a thin, flat cell right here, and you have oxygen inside of the alveolus, it can get transferred easily to a capillary. In this picture, Here's your alveolar airspace. So let's say there's oxygen here. We want it to cross into a blood vessel. So here we have our type 1 cell. That's the thickness of one, which is not that thick, very thin. And remember that the endothelium of a capillary is also simple squamous epithelium. So you have two layers of simple squamous epithelium, one for the alveoli, one for the blood vessel for the capillary. So you're crossing over a thin layer. And on top of that, this interstitial space, there's minimal fluid thanks to lymphatic vessels. So we're really making the distance between alveoli and capillaries very thin, easy for oxygen to cross and carbon dioxide to leave. Not all the cells in alveoli are type 1. Not all of them are simple squamous. Some of them are a bit more cuboidal shaped. You can see one here, one here, one here, one here. And then in our illustration, it's the ones in yellow. These are type 2 alveolar cells. Type 2, by being cuboidal, that means they have more room to produce. They produce something. They produce a class of chemicals called surfactants. What that literally means is a surface acting agent, surfactant. In a nutshell, what surfactants do is that they coat the lining of the alveoli, and by coating it, by coating the lining, it's not for lubrication, it prevents the alveoli from collapsing. Not, again, not due to lubrication or anything like that, but due to pressure. The simplest explanation or example I can give you is if you have a glass of water, just plain water, you put a leaf on top, the leaf will float. If you try taking water but mix it with soap, soap is an example of a surface acting agent. There's other surface acting agents out there, other surfactants, but soap is one of them. If you add soap to that water and put the leaf in, the leaf will drown, it'll sink. Try that with an insect. That's one way to get rid of fleas in your house. Put a light number, whatever, you can look that up later. But you can make things sink if you can reduce surface tension. This chemical is acting at the surface. You're reducing surface tension, and surface tension relates to pressure. If pressure is too high in an alveolus, that alveolus can collapse. Like if a tent has pressure pushing on top of it, that tent will collapse. Similarly, if you have an alveolus and something's pushing on it, like air pressure, that will collapse. But having surfactant inside the lining will reduce surface tension and therefore reduce pressure. You'll learn more about that in physiology. As far as this class goes, I just want you to know that there exist type 2 cells. They are more cuboidal than squamous, and they are the ones producing this surfactant to prevent the alveoli from collapsing. You want to use all your alveoli when you breathe. So it's really bad if one collapses, or if your whole lung collapses, that's not good. In COVID-19 patients and in other patients with other respiratory conditions, one thing that can happen is that alveoli can become very inflamed, meaning swollen. There's an increase in interstitial fluid. And the alveoli themselves can be filled with fluid. Normally when you breathe, take a look at this animation down here, there should be simple oxygen transfer into the blood vessels because there's a very thin separation from the simple squamous of the alveoli, small interstitial fluid space, and then thin simple squamous of the endothelium of the capillaries. But there's fluid buildup in conditions like people infected with COVID-19, and there's inflammation. There's a buildup of fluid in the interstitial space. And that makes it really difficult for oxygen to make its way past that barrier. More distance means slower diffusion. You can see that in histology. Not only can you see that in chest x-rays, you can see all this buildup of stuff surrounding the lungs, but you can see normally you have nice thin alveoli, but those alveoli are no longer thin. There's all this stuff in between. In conditions like emphysema, there's scarring, pneumonia, there's fluid buildup, bronchitis, there's inflammation of bronchioles. Either way, you're preventing air from coming in or you're preventing transfer of oxygen. Both cases make it very difficult to breathe. To recap, I'll come back to this, but I want to show complete anatomy real quick. This screen shows bronchioles and alveoli. You can see a respiratory bronchiole leading into, or sorry, terminal bronchioles leading to respiratory bronchioles. There's terminal, respiratory. You can see the alveolar duct right here. Whoops, doesn't show the whole individual thing, so I'll just trace it myself. There's an alveolar duct. This whole piece here is one alveolar sac. A single alveolus, I'm drawing in pink. And you can see surrounding alveoli, we've got many capillaries, pulmonary capillaries. There's also, I think I forgot to mention this, there's also lots of elastic connective tissue. Elastic fibers surrounding the lungs. The lungs themselves don't have muscle. We'll talk about that in a second. The lungs have elastic connective tissue because when you bring air in, they expand and you want to go back to original size. But I'm going to clear this. If we zoom in closer, you can see the distance between this is a type 1 cell of the alveoli, and then you've got your capillary right here. You want a small interstitial space in between that white space that I just drew. Switching back, slide 32. I've drawn a schematic of where we breathe in. It's a bit small here, but if you start, let's say in your nose, you can breathe in your right side or your left side. You get to your nasal cavity. You can go to your paranasal sinuses, but then you'll come back. You'll swirl around with the conch to the nasopharynx. Some air can go to the auditory tube. That's just for equalizing pressure. To the oropharynx, laryngopharynx. We could go to the esophagus, but that's for eating. Larynx, trachea. On the left side, you only have inferior and superior secondary bronchi, and it'll keep going, but I'm not going to show every single part here. And then on the right side, superior, middle, and inferior secondary bronchi. Secondary goes to tertiary goes to bronchioles. There's terminal bronchioles, which have muscle, respiratory bronchioles, which don't. And then we get to alveolar ducts, and alveolar ducts have many alveoli. And it's these alveoli that can exchange gases with the pulmonary capillaries, and that's how we recharge our blood and send it to the left atrium, then to the rest of the body. To make all this happen, the lungs need protection and the lungs need muscle surrounding it. Lungs themselves do not have muscle. There's smooth muscle lining the trachea and bronchioles, bronchi and bronchioles. There is not smooth muscle lining the alveoli. So you need skeletal muscle for breathing. To protect the lungs, this is review. You have the pleural cavity. It's the cavity on lateral portions of the thoracic cavity, lined by pleural membrane. You have visceral pleura, which is directly against the lung. You have parietal pleura, which is along the thoracic cavity. And this is serous membrane. Serous membrane is slippery and it helps keep the lungs propped up against the thoracic wall. These pleural sacs not only lubricate, create a slippery surface so that there's minimal friction, but it's holding the lungs tight against the thoracic wall. In this cadaver picture, if you cut the parietal pleural membrane, the lungs will collapse. And if in a real person, if you have a puncture of your pleural membrane, your lungs will collapse and it will be hard to breathe. It has to do with air pressure, and we can get into that another time. I'm not going to test you on air pressure, but it relates to that. If you open up this membrane, lungs collapse. You want to keep your lungs partially inflated even at rest. You never want your lungs to collapse. So having that pleural membrane makes sure that the lungs stick and stay inflated. I said that we need muscle to breathe. It's not smooth muscle. We need skeletal muscle. Skeletal muscle is attaching to the ribs and to the vertebrae, to the sternum, so that we can create as much pressure as we can in the separation between thoracic and abdominal pelvic cavities. Diaphragm flattens out. So it starts here and it flattens to make the thoracic cavity bigger. By making the thoracic cavity bigger, we cause negative pressure, decrease of pressure, and air flows in. That's needed for normal, quiet breathing. If you want to forcefully inhale, forcefully exhale, recall that we can use sternocleidomastoids, external intercostals, and diaphragm to breathe in, also scalenes, but we didn't discuss that. And then to breathe out, you can use the internal intercostals and rectus abdominis, external oblique, internal oblique, transverse abdominis, the abdominal muscles. So that was a quick review in those last slides about things you've seen before, and hopefully that refresh your memory a little bit. It's all relevant here because we're talking about breathing and the respiratory system. So hopefully I've made it clear to you that the respiratory system is for bringing air in, and as we bring air in, we want to humidify the air, we want to warm up the air, condition it, and we want to filter the air. Because if we get those particles deeper down to our alveoli, it gets really sensitive and will damage our lungs. And we don't want that. All right, that wraps up chapter 25. Please let me know if you have any questions, and I'll do my best to answer your questions, discussion, or in the comments section. All right, talk to you all later.